We close our series on adult ADHD with a practical guide to making the diagnosis and ruling out other causes. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. Last week, we looked at the history behind the better explained clause in the DSM. It revealed a secret world where some disorders are more valid than others, and adult ADHD hangs low on that totem pole. But first, a preview of the quiz. You can earn CME credit through the link in the show notes. Which type of depression did pramipexole improve in a new randomized trial? A. Inflammatory depression. B. Treatment-resistant depression. C. Anhedonic depression. D. Atypical depression.
I think adult ADHD is one of the most difficult diagnoses to make because it requires us to understand the cognitive profile of so many other disorders that could be causing the symptoms. The DSM doesn't help here, as these non-specific symptoms, like cognition and anxiety, are largely missing from the manual because they are common to all diagnoses and indicative of none. Take bipolar disorder. Several hypomanic symptoms overlap with ADHD, talking about distractibility, hyperactivity, impulsivity, racing thoughts, rapid speech, and irritability. You can see all of those in ADHD. Hence the title of that popular book, Driven to Distraction, both symptoms of hypomania. Now, at first glance, it might seem like it's pretty easy to sort this out because in ADHD, the symptoms are constant, while in bipolar, these hypomanic symptoms come and go. They're episodic. But many people with bipolar disorder have affective temperaments like cyclothymic or hyperthymic, where these hypomanic symptoms are going to be nearly constant. And again, at first glance, it might seem like that's pretty easy to tell apart. I mean, these affective temperaments ought to come with a lot of mood symptoms that we're not going to see in ADHD, right? But no, affective temperaments are nearly as common in adult ADHD as they are in bipolar disorder. So there's no easy way out of this morass to separate this overlap.
Okay, so we've covered two ways that bipolar and ADHD symptoms overlap: hypomania and affective temperaments. A third is cognitive impairment. Around 30 to 50% of people with bipolar disorder have cognitive impairments that persist after the mood episodes lift. Here's one way to sort these out from ADHD. In ADHD, cognitive symptoms start in childhood and improve with age as the frontal lobes mature. In bipolar disorder, they worsen over time. Each new episode acts like a small head injury, and the deficits accumulate.
The time course, like Kellie said, does help, but the specific cognitive problems usually don't. Cognitive testing turns up similar results in both ADHD and bipolar disorder, including euthymic bipolar disorder. In both cases, we're going to see trouble with working memory, verbal fluency, and executive function. Now, in bipolar disorder, the executive impairments tend to be more severe. Compared to adults with ADHD, patients with bipolar have less flexibility with changing rules, more trouble planning a complex task, and more difficulty filtering out irrelevant information. Now, those are all classic symptoms of ADHD, but they're actually more severe in bipolar. That leaves plenty of people with bipolar disorder who are going to be struggling with attention and organization, even when they are euthymic. And after a few TikTok videos, they might just start to think they have ADHD.
Before diagnosing adult ADHD, I check a short list of conditions. Finding one of these doesn't rule out ADHD, but it at least means there's more than one cause at play. Besides medical and psychiatric disorders, think about 1. Anything that could injure the brain: past substance use, vascular disease, inflammation, including obesity, and traumatic brain injury. 2. Anything that disrupts sleep, especially sleep deprivation and sleep apnea. 3. Medications that impair cognition, like anticholinergics, sedatives, opioids, and anticonvulsants.
Those are the treatable causes to rule out. Other causes of ADHD trace back to early childhood and aren't as easily fixed. Premature birth, drug or infection exposure in the womb, nutritional deficiencies in the early years, and childhood abuse and neglect. ADHD is neurodevelopmental, but both genetic and environmental causes can contribute in that early development, and it's still ADHD even when the cause is mostly environmental, as long as the symptoms are present from early childhood. Now, moving on to other causes, artificial food coloring does carry a small effect, and other environmental factors that are linked to ADHD include lead exposure, air pollution, hormone-disrupting chemicals, we find those in processed foods and cosmetics and pesticides, and screen time.
The more clear-cut a disorder, the easier the diagnosis. Adult ADHD, with so many possible causes for the same cognitive problems, is rarely clear-cut. Here's how we approach it in practice.
First, I use a structured interview to assess for symptoms, one that asks about the DSM criteria in plain English, like the DIVA for ADHD. For each symptom there, I'm going to ask how it looked in childhood and ask for specific examples. That way we can rule out people with like obsessive-compulsive personality who think that even minor mistakes in their work life represent ADHD. Then I'm going to follow that with a structured interview for the 12 valid diagnoses that need to be ruled out, the ones we mentioned in our last podcast. Now, the basic versions of the Mini and the Skid screen for all of those 12 diagnoses. They were designed that way. And if you like, I built a free version you can use on my website, psych-partners.com/DSM-5 interview. That's the number 5. That version also covers adult causes of ADHD, including the psychiatric disorders and brain injuries that we've just reviewed.
Next, take a developmental history, school records, report cards, and reports from anyone who knew the patient as a child. If they had symptoms but no impairment as a child, ADHD is still possible, but this requires some clinical judgment. First, confirm the symptoms were real in childhood, such as through teacher or parent report. Next, look for an explanation as to why they didn't have impairment. Do they have a high IQ? Did they have a highly structured household or attend an undemanding school?
As you look for impairments, ask specifically about transition periods, like starting middle school or high school, going to college, or the first year at a new job. That's where people's compensation strategies tend to break down.
Finally, consider malingering, including recreational use and diversion of stimulants. This is common. Last year, a survey of 84,000 adults who were prescribed stimulants found that 1 in 4 misused their stimulant, taking it differently than prescribed, and 1 in 10 met criteria for stimulant use disorder. Among college students and people with substance use disorders, the rates are higher. There are real incentives tied to an ADHD diagnosis, stimulant access, testing accommodations, and some adults with no history of the disorder will present convincingly. All this is to say, don't just rely on a symptom checklist. Take it from Keith Connors, who created the Connors rating scale. Toward the end of his life, Dr. Connors came to regret how those scales were used to diagnose ADHD. In a 2013 interview with the New York Times, he called the rise in ADHD diagnosis a national disaster of dangerous proportions and described rating scales as a concoction to justify the giving out of medication at unprecedented and unjustifiable levels.
Some practices use computerized cognitive testing, but this has no evidence to improve the diagnosis or rule out malingering, neither does general neuropsychological testing. Now, testing can help personalize treatment by flagging specific areas of impairment, but it does not distinguish ADHD from bipolar disorder, substance use, brain injury, or the other causes we've reviewed. Even though it doesn't clarify the diagnosis, some practices require cognitive testing to put up some barriers in the flow of stimulants. Now, I've never advocated for measures that slow down access to care, but here I can sympathize. Many practices that are getting inundated with requests for stimulants are requiring one of these 3 steps before finalizing the diagnosis of adult ADHD. 1, cognitive testing, or 2, family input, including report cards. Oh, actually, that's 3. Or 3, school records. Other practices are requiring urine drug screen, which you might consider doing depending on the population you're serving.
In our next episode, we look at what happened when a large practice did the opposite, removing barriers and speeding up stimulant access. The business and clinical leaders who created those pathways are now in jail, and the story carries lessons for all of us. Today's research update looks at a new option for anhedonia, the loss of pleasure and drive that shows up in up to 70% of patients with depression. The study comes from Frederick Ventorp and colleagues in Nature Medicine.
SSRIs don't do much for anhedonia and can make it worse by causing apathy, dampening emotional reactions to both positive and negative events. Pramipexole acts directly on the pathway that's thought to drive anhedonia, the dopamine D3 receptors in the nucleus accumbens and the ventral striatum. We've had uncontrolled data on pramipexole and anhedonia for years, but this is the first trial to test it against placebo in anhedonic depression.
Researchers randomized 82 adults with depression, dysthymia, or bipolar depression, all with significant anhedonia, to pramipexole or placebo. The medication was added to their current antidepressant for 9 weeks. Then everyone continued on open-label pramipexole for 6 months.
Pramipexole worked. On the anhedonia scale, it dropped scores by 6.5 points versus 2.5 on placebo. That's a moderate effect, and it showed up by the 3rd week. The patients on pramipexole were also less apathetic, and they moved about more. That was measured by an accelerometer. The symptomatic changes here were backed up by brain imaging. Pramipexole preserved reward activity in the ventral striatum, while that activity declined on placebo. The average dose was 3.5 milligrams a day, which is higher than most trials and higher than I would recommend. That kind of dose can cause more hallucinations, though none of them were seen here. Instead, pramipexole in this trial caused sleep problems, nausea, dizziness, and anxiety. Now, I've used pramipexole for over 20 years, and I usually dosed it in that time up to 1.5 milligrams. But now I push a bit higher based on studies that show better results at 2.5 milligrams for highly refractory depression. But 3.5 milligrams like they used here, that's higher than I've ever gone with, and I'm not comfortable with it yet. The main limitation in this study is that blinding was not imperfect. The placebo patients guessed their assignment around 2/3 of the time. It was also a small trial.
The bottom line, if your patient has significant anhedonia or treatment-resistant depression, consider pramipexole, either as monotherapy or augmentation. I'll often explain it this way. It looks like you've tried a lot of medications, but most of them work on the same neurotransmitters, serotonin and norepinephrine. Have you heard of dopamine? It's involved in motivation and drive, that feeling that tasks are rewarding and life is meaningful. Patients usually respond positively, and I'll add, you've never tried a medication that targets dopamine directly. This one does. It never gained FDA approval because its antidepressant effects were discovered just as it was going generic. That opens the door to the main risk. If pramipexole pushes your drive too high, you do too much, like overspending or other pleasurable activities, but there are no reports of excess substance use on it. Learn how to use pramipexole in Dr. Aiken's book, Difficult to Treat Depression, available in print or audio. The book ranks medication augmentation strategies by their evidence, starting with lithium, antipsychotics, and pramipexole, followed by thyroid and celecoxib, then amantadine, D-cycloserine, and minocycline, with ketamine reserved for antidepressant acceleration. Each chapter explains when to use it, how to dose it, and how to manage the side effects.